Thanks. So maybe we'll be able to get out of here before 4. Thank you for being willing to change your hours. Barbara is an important part of the conversation. And you know, when we are talking about, let's say, Stark, or any of the various regulatory things that we've talked about, there's what you'll learn in the book, and then there's the reality. So a lot of people talked about the advantage of how the QE-TAM lawsuits kind of kept check on things, and you know, various things like that. But the realities, at least along the fringes, the things that Barbara deals with are can be kind of terrifying, because even if you're somewhat aware of the regulation, you can get yourself in serious trouble by and need an attorney, and she's the one to call on if you do, because she's so she'll tell some tales about how people in healthcare have stumbled into unfortunate circumstances that have, and some of the tales actually kind of make the hair on your skin stand up, because it's they're easy to do, easy to step in it. So she'll lend an edge of reality or to it. And actually, the last time she spoke, it was with the MBA class, and I had a number of people come up to me after the class and said they no longer wanted to be hospital administrators. I don't know if they were kidding or not, but you can get a sense of the necessity of having a good attorney when you do when you need hospitals or people in healthcare managerial positions do get into trouble. Let's see, a few housekeeping things. I timed my bilateral knee replacement to take place right after our first face-to-face. It's been 5 weeks since my bilateral knee replacement, so come on in. Please sign in and get a name tent card. Are you looking for healthcare regulation and legislation?
Yes.
Yes, there is. We're in the mysterious room without a number.
We are.
Yes. Thankfully, you found us. So I'll be intermittently sitting down and this and that as my knees allow me. Let's see, we have lunch here about 12:30, and Barbara is expected about 1, and we'll talk about the professional staff structure, the structure of hospitals, and some other things between now and then. Are there other housekeeping things we need to talk about? Kimberly, once again, is recording the session, so for those who aren't here, they'll be able to, you'll probably be able to post this, and they'll be able to take a look at the lectures, which will be particularly helpful. Will be available to you if you have to leave early and miss part of Barbara's time. Questions about today? Comments? Thank you all. You've really exceeded my expectations in your postings about a variety of things about Stark, and this week's postings were really, you've done a really good job. Please, hello, this is the room without a name. Please sign in, right? Please sign in right there and grab a name tent. And there are a few things that came out of this week's discussion that I thought we could discuss here. Some of the questions, I put them in the, I've had an instructor's post thread created for each of the weeks, so I've been able to, it's a little frustrating because I'll answer someone and it'll be visible only to that group. So you'll notice at the top of each of the weeks there's an instructor's posting, and I put some threads in there now and then when I thought that some of the things I should be saying were relevant to everybody rather than just to the individual thread that I might be responding to. Let's see. Anything else? Questions, comments? How is the class going for you all? Okay.
Super.
Any change in emphasis that you think would be appropriate for your jobs, or anything in particular that you'd like to make sure we cover?
I think just because I'm a nurse, it seems very physician-centric.
Mhm.
So the only thing that I would suggest is that maybe 60 for other professionals as well. I think we've thrown in comments from the other side.
Right.
But that would be
Yeah, interestingly, I think that the nursing profession has increasingly been concerned about compliance issues relevant to them. A lot of the compliance structure, as you've seen, seems to be revolve around physicians, but some things like HIPAA, of course, are relevant to the nursing staff. Advanced practice nurses can bill and can get into the same sort of trouble that others can with billing. But I can keep that in mind. Yeah. And we'll talk a little bit about that today, in the sense that, why don't we dive into that? That's good advice, thank you. How are hospitals, well, let's see. Let's start from the beginning. So originally there were, as you probably know, there were a jillion hospitals. Anybody could set up a hospital. They'd set up a hospital in the back of their house. And they'd hold people overnight, and I guess they'd charge the patients for whatever they were doing to the patients. And then 100 years ago, physicians organized in a way that was insisting upon more regulation of hospitals and control of quality of the hospitals. In particular, one big effort was from the American College of Surgeons, which organized what eventually became the Joint Commission when they paired up with the American Hospital Association and others. But they organized themselves in a way that insisted on quality standards for hospitals. So this was largely physician-led. So that's some of the history that's behind the way hospitals are organized now. So what you see here in the preamble to a standard set of bylaws is that it kind of sets out the language for how hospitals are really entities that have two different pieces to them. One is the hospital itself. So the hospital has, the typical hospital has it has a governance structure with a board of directors that runs the hospital and is in charge of the hospital, usually, and reporting up to that board of directors is an administrative structure. Usually, the hospital administrator reports in a fairly simplified system. I know we have a lot of complex systems, but the hospital administrator reports to the board of directors and is responsible for the functioning of the hospital. That functioning of the hospital includes hiring the staff, most of whom are nurses. Okay, so there's nurses, the physical therapists, the nurses' aides, the housekeeping, security, the mechanical engineers, all those people are employees of the hospital. And in that sense, their boss ultimately is the hospital administrator. Now, things have gotten obviously a little, there are shades of gray, many shades of gray, but in the traditional sense, there is that. That whole structure is governed by employment law, which has to do with the relationship between the employees and the employer. That's things like, Taft-Hartley and the right to organize and to, hello, please get a tent card and sign in the back. Harassment stuff, all that sort of thing. And so all of the HR stuff is dealt with through human resources law and regulation, which for a hospital necessitates an annual performance evaluation, and hospitals are evaluated by whether they have done I should be in the video, I guess, here. Hospitals are evaluated by whether they've done annual performance evaluations, and that's one of the things that the Joint Commission looks at. In addition, there are training requirements and educational requirements, compliance training, all those sorts of things that the hospital employees have. And then there's the professional staff. And the professional staff is none of those things. The professional staff does not report to the hospital administrator. They are not employees of the hospital necessarily, in the idealized sense. Some hospitals employ some physicians. But they are physicians who work at the hospital. But it's not just that they work at the hospital. They have a responsibility to the hospital, and indeed it, Carolyn, would you sign in the corner and get a tent card? And they have actually membership in the professional staff. So for those of you who weren't aware of that, and most people are not, the professional staff is the organization of clinicians who practice at the hospital. Now, in my hospital, professional staff is defined as MDs, DOs, doctors of osteopathy, podiatrists, and dentists. And only they are eligible to be members of the professional staff. So the professional staff is governed by a whole series of rules, but it's different from employment rules. The professional staff organization is that all members of the professional staff are members of a department. Each department has a department chief who is responsible for the quality of care provided by those clinicians. And in actual fact, I don't know that I could whether I can find it or not, but it's responsibilities of the department chief. So the department chiefs are members of the department, and they have responsibilities 1 through 15. So you can see they are responsible for the continued surveillance of the professional performance of all the individuals with delineated clinical privileges in the department. We'll talk about that in a second. Assessing the competency of the clinician, continuous assessment and improvement in the quality of care and services provided, the criteria for clinical privileges, we'll talk about that, reappointment, et cetera, et cetera. So they're really the people in charge. Now, to whom do the department chiefs report? Well, they report to, in my hospital, they report to me as the chief of staff. So that's the structure of professional staff, the independent professional staff organization of the hospital. And that's really what it's about. So there are criteria for joining the professional staff, and we can look at those. They're in the beginning of the bylaws, the B1. There's a whole list of criteria. You have to be, physically able to do your job. You've got to have high ethics. You've got to work cooperatively, demonstrate that you can work cooperatively. You've got to be able to demonstrate that you have the competency to perform the things you are asking to do, and we'll get into that in a second. And so there's a very rigorous application process, some of which is dictated by ICWIA law. Then the next section of the bylaw talks about the reappointment process. So once you become a member of the professional staff and passed a whole series of hurdles to become a member of the professional staff, every 2 years you need to be reevaluated. So whereas employees of the hospital are evaluated by annual performance evaluation, members of the professional staff are evaluated through the reappointment process every 2 years. So every 2 years, the department chief sends out a bunch of information that says, we've looked over your quality, your med legal, your utilization information, patient complaints, and we think you are fit for reappointment, and recommends that to the Credentials and Privileges Committee, which recommends it to the Executive Committee, and is signed off by the Chief of Staff, or not. And if not, then at the time of reappointment, usually what takes place is a work plan for the physician, the members of the professional staff to improve his or her performance. And that's fairly routine process that happens for physician members of the hospital. As part of the application process, the physician says, I am a neurosurgeon and I'm skilled in doing base of the skull surgery. So how do we know when someone asks to be a member of the professional staff that that physician is qualified to do that? What are some of the things that you might think would be criteria that I could look at, or the department chief could look at, and to figure out whether Dr. Smith is actually qualified to do base of the skull surgery?
Credential.
What's that?
Credential.
That's ultimately what it's called, but what would be the components of the credentials?
Board certified.
Birth certification
So
and
board
the
certification,
specialist.
education,
Number of procedures performed.
so past work experience and
Outcome.
outcomes, exactly. And some of those things can be determined by peer evaluations if they worked elsewhere. And it's very common, for example, if someone comes out of training, to get a letter from the head of the training department, the department in which the clinician trained, attesting to the qualifications, but not only to the qualifications, also the types of surgeries that the neurosurgeon has done in the past, usually including numbers. So if I am familiar with a situation where a cardiologist was hired because she was a professor and had taught lots of people to do electrophysiology studies, endomyocardial ablations for supraventricular tachycardia, things, a certain type of angiographic procedure intervention, and when she actually got on board, she had terrible hands. She just couldn't do it. She just couldn't do it. She just was not sufficiently dexterous or skilled at the technique to be qualified to do it. And in spite of the fact that she had all these credentials, so she was board certified, taught how to do it. Obviously, she taught them, but not done them. So she had to leave the professional staff because she was unable to do that. That was determined during a period of proctoring. So when someone joins the professional staff and says, I can do skull-based surgery, base of the skull surgery, and all those things are evaluated, they also go through a mandated period of proctoring. Now, the Joint Commission, in its wisdom, has now chosen to call that FPPE, because the board knows proctoring is too ordinary a word. So it's now called Focused Professional Practice Evaluation. It's proctoring. and that involves what proctoring is for any particular department depends on the wisdom of the department chief and the acquiescence of me and others who evaluate what the department chiefs do. But usually it's a period of 6 months where other members of the department who do base of the skull surgery scrub in and evaluate the technique of Dr. Smith and whether Dr. Smith is doing it in a standard fashion. Now, there are circumstances where someone might say, I'm going to do robotic GYN oncology and surgery, and nobody else in the hospital does that, where someone has to at least sign in and get a tent card in the back, where the hospital, in order to do sufficient proctoring, has to get told someone from OHSU to come down and proctor the clinician doing those surgeries, or someone from out of town, some visiting expert to come in and sit in and do the proctoring. But that's not uncommon as technology marches forward. But that's That's also something that happens. So those are the ways that clinicians are evaluated as to their competency. And what? Oh, you had a question?
Even in the board certification process, then, there's not an evaluation of the technical skills, the dexterity? How is it she got through board certification without that being picked up?
Sure. So, and that was my next topic, the board certification question. So board certification, so the training process for physicians is medical school and then some tests. And if you pass those tests, there's a year of internship and a test. And after the year of internship, you can make application to the state. Usually, most states require a year of internship. I'm not sure if Louisiana does, but you require the year of internship, and then you can become a physician. You can become a licensed physician, have a number, and a certificate from the state saying you can practice medicine. Most people these days, that doesn't get you very far. You could hang up a shingle out, outside your office and say, I'm a physician and these are the things that I do. And you can do whatever the hell you want. But if you're going to do something that requires that you practice in the hospital, that's a little different. So you might have read about Jerry Darm. And Jerry Darm, he's a physician who, I'll probably get sued for mentioning it, but someone on a blog said, my God, look at this. I mean, he's not a plastic surgeon, but he's advertising plastic surgery, and he's had his run-ins with the Oregon Medical Board, because you can find that on the Oregon Medical Board website. Jerry Darn can do whatever the hell he wants, because he's a physician, and it doesn't involve hospital. So his plastic surgery is done outside the hospital, and he can go to a training course and learn liposuction and buy the machine and do liposuction until the cows come home, or buy Botox and start injecting it. If, however, Jerry were to do procedures that required care in the hospital, it would be a completely different thing. There's no way in hell any hospital in the United States would allow someone without formal training to establish a practice and have privileges in the hospital for something that they hadn't had training to do. Now, if he could demonstrate that he had experience doing something, that'd be different. However, without the training, if you have the experience and you can demonstrate that, then that's perfectly okay. However, I don't know how you would get the experience for doing things that needed to be done in a hospital, because nobody would give him hospital privileges without the training to get him to foot in the door. So with that type of exception, what most physicians do is go on to post internship training. So you can do 2 years of internal medicine, 2 years of pediatrics. You want to do neurosurgery, it's probably about 8 years. General surgery is probably 5 years. Dermatology is probably 2 years. I mean, so most people go through a training program, and then whether you're board certified or not depends on whether you take the test and pass the test. So board certification is different from having done the training. And indeed, it's a little complicated because I believe it's OBGYN. You can't sit for boards, they call it. You can't sit for boards until you've had 2 years of post-residency experience. And you've done so many deliveries and this and that and next. So you can't even be board certified for 2 years after your training. So those people are board eligible, but not board certified. So the phrase board certification is a little tricky and a little complicated, because it's not necessarily the same as being trained in a specialty. But that said, most urban hospitals won't allow someone onto the professional staff unless they are board certified or board eligible. And indeed, most hospitals that I'm aware of, if you're board eligible and when the time comes you don't become board certified, you're no longer a member of the professional staff. Indeed, most urban hospitals these days board certification now runs out after 10 years, and you have to do a bunch of continuing medical education and take a test again in order to become recertified. Most professional staffs now require that you maintain board certification. And so if 10 years have passed and your certification in OBGYN has lapsed, you have a couple of years in which to become board certified again, or you lose your standing in the professional staff and can't practice at the hospital anymore. Did I answer your question about that? It is a complicated question.
So I'm not sure if she never took the training, and that's why she never took the specialty training, and that's why she got that far.
Oh. Yeah, she did the training, and sometimes she had some degree of proficiency, apparently sufficient to allow her to say that she could do this. But for a lot of these techniques, and it could well have been the case for her in this instance, that you become board certified and then new technology comes along and you learn the new technology. And whether you, and how proficient you are after you learn it, depends on your skill level and how many you do and this, that, and that. And then there's a phenomenon that's not, here I am sitting in OHSU talking about this, but it's not uncommon to find that someone from a really high-powered training program doesn't have much in the way of technical skills if they don't have a lot of experience taking care of a lot of patients. So for a lot of hospitals, a lot of hospital training programs, the number of patients that they actually care for is diminished substantially. And you've got a whole bunch of people taking care of relatively few patients because the people who have been trained are out in the community taking care of those patients. And so sometimes it's the case that people come out of training programs. For example, there's my uncle is an OBGYN doc, and he used to talk about, in Northern California, he used to talk about Stanford grads being terrible OBGYN docs because as they come out of residency, but as a resident, they were, kind of behind the attending and then the fellow, and then maybe 2 years worth of fellows, and then the OBGYN resident in the last year, and then the OBGYN resident in the next to the last year. So by the time you actually see the patient, you're not doing any diagnostics. Everybody has already, patient's way down the road. So it can be difficult to assess how that has actually played out for people. So the proctoring obviously is important. It's an important component of the whole thing to see whether people have the skill or not. Yes?
I had a question about certification of maybe physicians, and then nurses could chime in as well. As a pharmacist, once I have my pharmacy license,
Right.
I'm good to go as long as I do the CE every year.
Right.
And I'm also board certified, so I have to take a test every 7 years. And I always really applauded that physicians have to actually go in and take a test to, keep their board certification.
It's more than a test. It's a very involved program.
Right.
Go ahead, Pat.
Right. So if you were, let's say, not a board certified physician, or maybe what I hear you saying is everybody is, do you?
No, newly hired. Newly hired. Yeah.
Okay, so if I'm a PCP with, without a board specialty,
Yeah, sure.
what would I have to do to maintain my medical license? And then I'd like to hear from the nurses about what they have to do to maintain their credentials. Do you have to do certain number of CE hours? Do you have to take
you use a few words. Maintain your certification versus maintain your medical license. So to maintain your medical license, every 2 years you need to send in $500 or $600 to the Oregon Medical Board.
Yeah.
And then you have to attest that you've taken so many hours of continuing medical education over the preceding
60 hours.
2 years. Now, the medical education, with just rare exceptions, doesn't need to be even in your field. It can be fairly generic, but that's the requirement. And then you need to be in good standing, so you need to be able to check off that you've not had your privileges taken away from you or been arrested for something or this, that, or the next. And those are the requirements for the state. For certification, It's a very involved program that involves a lot of continuing medical education just for the board recertification. You have to, in some specialties, such as mine, you have to do a quality improvement project at your hospital and be able to demonstrate what the results of the quality improvement project were. And then you have to take a day-long exam that gives you a splitting headache. And then have passed the exam. And 10 or 15% of people don't pass, something like that.
What about the people who are, don't have to get, like in internal medicine, some folks are grandfathered in. So they don't have to go through the board certification.
That's correct. Yeah, the grandfathering occurred about the requirement for recertification every 10 years occurred about 25 years ago. So it's just older physicians that are grandfathered in. So they so they don't have to recertify to maintain their board certification. They still have to, if they practice in a hospital, go through the every 2-year reevaluation and maintain continuing medical education, which is a requirement of reappointment at the hospital, that sort of thing. So really the scary situation is you've got a 70-year-old physician who's got only an outpatient practice and who went to medical school in the middle of the last century. They have no idea what the quality of care is if it's a solo practice. When you get into larger and larger practices, especially practices that share a common medical record, it becomes more and more apparent that there's a fairly standard quality of care being provided because everybody's taking care of everybody else's patients, looking over everybody else. People are looking over your shoulder all the time. And there are mechanisms for feedback and evaluation within that large group practice. But in solo practices, especially outpatient practices, you just don't know. There is increasingly the requirements for reappointment have gotten more and more stringent. And so, for example, in OBGYN, a lot of physicians are doing more and more gynecologic surgery, GYN urological surgery, and focusing their practice on that. And then if your hospital has nurse midwives, they do a lot of the normal births. And so it's becoming increasingly difficult for OBGYN docs to get a sufficient number of vaginal deliveries to maintain their privileges to do that. Whereas you'd think that would be kind of, at the heart of being an obstetrician gynecologist, but it can be difficult for them to maintain a sufficient number to be reappointed with that privilege. So let's talk about privileges. Is it okay to move on? Do we have other questions?
You asked about the nursing certification too.
Nursing certification, I'm not all that familiar with. There are. Did you want to talk about it?
I can answer it for you.
Yeah.
Most of the nurses in here probably answer, but I'll answer it for you. So nursing certification, first of all, is not required, and pretty much most hospitals you probably find somewhere around 20 to 30% of the nurses that are certified. I think we're like at 42 in the hospital or something like that.
Critical care was 50%.
Yeah, critical care is usually a little bit higher.
Critical care and oncology, perhaps.
There's lots of different certifications for nurses, depends on what field that you work in, what area of emphasis you work in, and so nurses work in specific areas will take the tests that they're required, they'll have. You're not required to have it. I know at OHSU there's a bonus for doing that. There's $1,000 a year extra if you have your certification. So more so, it's probably a personal thing for the nurse to do that than a requirement.
And I think units have cultures where that's encouraged.
And there are, exactly.
Right.
So some units, even at our hospital, their certification percentages is much higher than other, even ICU units. You'll find some of ours are 50, 60%, some of them are 20 and 25%.
And your name's on
ICU.
file.
So they get the young man pictures out, right? So there's a little bit of like unit pride that you're part of that certification process. And then the requirement to keep your certification up, typically on the national certifications, I believe every 3 years, you have a certain number of CEUs that you have to keep up. And like the state boards, you send your money in and you prove that you've taken CEUs. And they usually require at-bedside care time too. So I know the RNC for neonatal is you have to have done 2,000 hours over that span of time, which basically you have to work half time. And it has to be at the bedside. And that's where some of us who were certified work in management can be certified in that certification anymore, but there are other certifications for management and things that you can do, but, and that's usually just paying the money and getting the CEUs, and then licensure is different in every state. We do a standard test for nurses, those of you who are not nurses may not know that. We do reciprocity in most states, you just apply once you've already had your license done, and you ask that state if you can be a nurse in the state. A lot of nurses hold multiple state licenses, Washington, Oregon, California, those of us from the military did that. And you just pay. Oregon doesn't require continuing educations every year, California does. So for every 2 years, Washington does every 2 years, in California you had to have 30. Oregon, they just ask you for your $100 and something and say, thank you, you're not in trouble, give us your money.
One time during your licensure in Oregon, you have to do a pain class, but that's the only continuing education the
That's right.
state of Oregon requires for nurses.
Requires the same for
California, I'm
physicians.
required.
30, I think, it used to be 33, yeah.
Yeah,
Every 2 years.
30-something every 2
years,
years in
yeah.
California. Oregon requires work hours only. There's only 2 work hour states in the nation, Oregon and Rhode Island. And I know because I had problems getting my Oregon license, even though I had an active California, because I had not worked 3/4 time in the previous year before I applied to Oregon, so.
So it's only Oregon that requires that? That's a pretty common
Oregon
problem.
and Rhode Island are the only work hour states.
Interesting.
And because I'd taken some time off to raise my kids and applied to
Yeah.
Oregon because
Yeah.
the Boy Scouts were wanting me to help them out at camp, Oregon said absolutely not. And they wouldn't even talk to me because I had not worked 3/4 hour in the previous year.
But they only require that initially, they don't require that after, when you do license.
So and then from the hospital's point of view, the hospital requires the nurses to do annual testing, and then testing for new IV pumps and when things come along, competency training for certain
training.
things. And that's sort of an ongoing thing within hospitals for nurses.
And some hospitals require continuing education also.
Yeah.
I worked through the VA, and actually I started working through the VA on my California license and have since been able to get the Oregon license
Oh,
also.
okay.
But the Oregon the VA requires a lot of continuing education for
The VA
nurses.
has very high standards.
Well, you can also
So-
practice under your state license because you're a federal institution.
Right, you
There we
can,
go.
any state license, you can work for the federal.
I know LPN,
And of course, depending on your licensure too, so if you're NP, nurse practitioner, then you have different, that was basically for just bedside RN, regulations.
So in the same way that there's some oversight of physicians through the Oregon Medical Board, there is oversight of nurses through the nursing board.
there's also Oregon mental health, you have social workers, psychologists, LPNs, they have state certification, CE requirements and licensing,
Mhm.
and then the psychologists have national certification.
Okay, good. And some hospital psychologists can be members of the professional staff.
And again, federal's a little different because the staff is part of the hospital,
Right, sure.
most of it.
So so when a physician applies, back to the physician applying to the professional staff, the physician asks for privileges. Now, privileges are kind of a laundry list. I'm an internist, I can read an EKG, I can do a thoracentesis, I can do a paracentesis, I can do a lumbar puncture, some very basic sort of invasive procedures that are delineated out. And then coming out of training, usually the physician will have done a sufficient number to qualify and get those privileges. Then at time of reappointment, the department chief, the clinician at time of reappointment requests, I want to continue doing this, and I don't want to continue doing that because I haven't been doing it. So then the department chief signs off on that, and if that gets approved, then the privileges have changed. So if I haven't done a lumbar puncture in 2 years, I'll say, well, I don't think I should do lumbar punctures anymore, and you don't request that privilege, and it drops off the privilege list. Now, this is particularly important in the operating room. So if you're not quite sure who Dr. Smith is, and Dr. Smith has scheduled this complicated surgery, and you know that this surgery is a base of the skull-based surgery, someone in the operating room usually should look up Dr. Smith's privileges, and they need to have the privileges available to them. So both people in the operating room, the scheduler or the head nurse or someone, will look up in the book and say, oh, okay, Dr. Smith has that privilege, or Dr. Smith doesn't have that privilege. Let's ask about that. And that would usually go to the department chief or to someone who would look and see whether Dr. Smith has the privilege to actually do what Dr. Smith scheduled himself to do.
What's the likelihood that nobody's gonna check on that and that the procedure actually is gonna be completed? And what are the repercussions if a physician doesn't have a privilege to do something, but he or she does that, it goes swimmingly, it's fine, and then somebody finds out after the fact? What are the repercussions of that?
Right. So I can't really answer the first question. It's become increasingly common that regulators, especially the Joint Commission, will look for evidence that takes place at the time of their survey. So if you can demonstrate that that's part of your process, that's good. If you can't, they might dig in further and see whether this is a problem or not, and actually cite a hospital on that. So it's that kind of oversight. Of course, a quality institution will have been concerned about this possibility to begin with. In my particular institution, pretty much all the physicians are a member of the same physician group, and so there's not a lot of mystery. It's rare for a new doctor to come walk in and do something that the operating room hasn't seen before, seen them do before. So that's less of a concern if you were in a hospital, in a big urban hospital that has a lot of big professional staff, and maybe docs that practice at a variety of hospitals. Then you'd have to be more concerned about that. You have a question? I'll get to you in a
Not a
second.
question, I could just comment to that at OHSU
Yeah,
actually,
yeah.
because I get called about physicians with privileges on kind of a regular basis at
Uh-huh.
OHSU.
Uh-huh.
And so we actually have a database that we can search and see what physician privileges are. Typically, it's anesthesiologists that are actually calling to ask those questions.
Well, that's interesting.
Yeah, it's typically the anesthesiologist saying, hey, I haven't seen this physician do this procedure before, are we sure that they're able to do that?
Well, that's a good system because
Yeah.
they would be knowledgeable about how to translate what's on the paper into the procedure. Yeah, that's a good
So that's kind of
system.
typical at OHSU.
Yeah, so the consequence for them having done that is I think it varies from institution to institution. In my institution, it would be flagged by the Credentials and Privileges Committee, and they would talk about it. It would go to the Medical Executive Committee, and it would be talked about. And by the time it was talked about, there would have been an intervention by the department chief or the chief of staff with the physician finding out, hey, what's up here? And so in terms of other consequences, it would be a ding for the physician. It would come up at the time of reappointment. If it was part of a pattern of inattention to important detail, then the physician would probably end up being disciplined or put on a performance improvement plan.
Is there some sort of process that is required? I mean, you said there's some intervention. So if you were to find out that this had happened.
Had happened. No, so-
Had happened.
Uh-huh.
And, would you step in and can you immediately suspend privileges? Can you,
Oh.
and then does that physician have a process that he or she is entitled to go through before any decision is made about their continuing privileges?
Sure. So, let's see here. What a perfect segue.
I guess that kind of also begs the question why a physician would be stupid enough to do something in an operating room that he or she knows that he or she doesn't have privileges to do too.
The physician's capacity, the average physician's capacity to be inattentive to administrative procedure knows no bounds. Okay.
So I have a question
Quote
going
of the
back. The
day.
lady who was applied for the cardio job,
Yeah.
one would think they're aware of their own dexterity. And why would you apply for a job knowing you couldn't really perform the job?
It was even worse than that when in this particular case, when she was informed that she wasn't performing up to snuff, she was unable to have insight into her lack of skill. So I've counseled a lot of physicians, and my general rule of thumb is that for Dr. Smith, who did something he shouldn't have been doing, or for this lady, or for a broad array of physicians who get into trouble doing these things, about by the time I talk to them, I close the door in my office and we sit down at the table. About 2/3 of the physicians and clinicians in general, I mean, not just physicians, but affiliated clinicians, allied health clinicians, they're called in the bylaws. About 2/3 of them are able to have insight sufficient to change their practice. And about 1/3 aren't. And when I detect that they are the 1/3, I'm relentless in my documentation. Because, I'm getting them out the door. And that happens about 1/3 of the time, unfortunately. We did have a surgeon who had very high standards for himself, and as a consequence, he felt like everybody else in the operating room should have equally high standards. You know how that translates. So, and he had a little difficulty communicating with the operating room staff.
Shocking.
What's that?
That's shocking.
Yeah, shocking. Can you imagine? And it was a thoracic surgeon too. That's shocking, right? So finally, when no member of the anesthesia staff was willing to operate with him, everyone of them refused.
You need those.
He was summarily suspended. So getting back to Felicia's question, Felicia. I had you look at a site that listed the requirements of the Healthcare Quality Improvement Act. And if you went through that, there's item 25, item 30. I mean, there's a big long list of things. Toward the middle of that URL, that site, there were a whole bunch of requirements. And it's interesting that all those requirements that are listed in the Healthcare Quality Improvement Act have to be translated into the hospital bylaws. So all of the things that were listed in HCQA got put into the bylaws to become the due process for intervention with members of the professional staff. So here are the qualifications. There's a reappointment of professional staff members. Here's reappointment, so that's what happens every 2 years, and this is the whole process for that. And then, boom, B4. Clinical practice monitoring and education, investigation, corrective action, suspension, and resignation. So in this section, which comprises the largest hunk of the professional staff for my hospital and probably for all hospitals, are all of the details that were contained in the Healthcare Quality Improvement Act. So the background, just very quickly, to HCQA is that the short version is that doctors are obliged to do peer review. And a whole bunch of state law, there's a whole bunch of state law about peer review, and a whole bunch of words that indemnify doctors for taking adverse actions on their peers on the basis of peer review. But when it came down to the Patrick case in our Astoria, Oregon, the Supreme Court ruled, no, you can't do that. You can't sit as competitors and do peer review. They basically shut down peer review. And they did it in language that was fairly sweeping and made it, and had a chilling effect on peer review all over the United States. So suddenly, nobody knew how to do peer review, you're uncomfortable sitting in judgment of the guy that works next to you anyway. But when all the protections, that the legal protections go out the window, then why would I subject myself to the possibility of treble damages? I knew Dr. Rappaport. Dr. Rappaport joined the Astoria Clinic after they'd done all these things to Dr. Patrick. Dr. Rappaport was just a meek, mild pediatrician. He's named in the suit. And Dr. Rappaport was paying Dr. Patrick for decades, writing him a check every month because of treble damages mandated by the eventual action of the United States Supreme Court. No physician in his or her right mind would subject him or herself to that. So peer review shut down. So Dr. Wyden, Mr. Wyden, Senator Wyden saw, this is my Machiavellian approach, thought about this, saw an opportunity. He said, I think we ought to have a database so that professionals who get into trouble and cross state lines have a trail. Okay, so I think we ought to have this practitioner database. And of course, organized medicine was saying, like hell. Okay, and so basically in HICWIA, Ron Wyden married the resumption of protection for peer review with the National Practitioner Database and put them all in one act called HICWIA. So HICWIA has all this very detailed language. If you tell the doc exactly what you think is going to happen. I mean, a lot of the things that didn't happen in Patrick, if you tell him exactly what the charges are, what the concerns are, if you give him so much time to prepare himself, if you give him an opportunity to talk to you face to face, if the members of your committee do this in total secrecy and blah, 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 and et cetera, et cetera, et cetera, if you do all those things, then you're protected, legally protected from the consequences of what you've done. So that's all in section B4 and B5 of the bylaws. And one of those, so I think I'm getting to where we were. So one of the things that's available within the professional staff structure is summary suspension. And I've done that. So when a physician screws up badly enough, or kind of the last straw in a continuing thing, I can call them up and say, I'm sorry, but I know you've got cases scheduled this afternoon, but we're going to have to figure out how to take care of those patients because you're leaving the hospital. Last time I had to do that was last year. In a case where I discovered that a member of the professional staff had been arrested for drunk driving in Idaho and had 2 previous drunk driving arrests in Washington State, about which I was not aware. And it became apparent that he might have to serve some jail time because of this arrest in Idaho. So it's like, he'd never been impaired in the hospital, but, you're summarily suspending. So if that summary suspension, that then entitles the physician to a whole series of fair hearing rights, B4 and B5 in our bylaws, and it's a big deal. The interposed between the department chief and the chief of staff is the medical executive committee, which is a collection of all of department chiefs of people who work, members of the professional staff, and usually the hospital administrator and the chief nurse also, and chief nurse executive. And that's sort of the body that sits in judgment of people. So within so many days, we have to sit in judgment of what this physician did and take action on the basis of it.
But you have independent power, though, to act without process immediately if you feel that there's a need to do so.
Absolutely, as does the department chief, members of the executive committee, and the hospital administrator. If the hospital administrator does it, then the process is sped up. The process of evaluation is sped up because she's not a peer. But there's a whole process for that. but it has to rise to the level of sufficient egregiousness that, you know, to warrant it. It's usually, it's pretty unusual that, that you have to do that. I mean, it's really either in cases where there's a pattern and there's been counseling and this and that, and it's like, you know, this is what I told you would happen. If it happened again, it happened again, and now you're out of here. Or something more difficult. Look, just as an example, there's a case, and this is an interesting interplay between the two entities within the hospital. Managers came to the chief nurse executive who went to the hospital administrator and said, this physician X is intimidating us. And this is an intimidating work environment. Not sexually, just intimidating. And we all knew this guy could kind of be an asshole, you know, but it never risen to that degree. So the hospital administrator said, we'll do an HR investigation because it's my employees that are saying this. So the hospital did an HR investigation. The result of the investigation was that this physician had exhibited a pattern of harassing behavior toward the managerial staff in the hospital. So what could the hospital administrator do? Not a hell of a lot. She really needed to work through the professional staff structure. So she came to me. Of course, I was aware of this the whole time. But and then it's then up to the medical executive committee to take action on Dr. X, and went through an entire independent investigation and ended up in that case he resigned while under investigation and is reported to the NPDB. So, I mean.
So just last question, sorry,
Yeah.
I'm taking up so much time with this, but so does conducting a procedure without having privileges rise to the level of egregiousness that you would be incited to do a summary suspension?
Sure.
It does.
The issue is an issue of quality of care and danger to patients. So it would depend not so much on whether the clinician had privileges or not. It would depend more on whether the clinician had any reason to do that, had any competency to do it, had done them before, or whether the clinician was just being a cowboy. See what I mean? So if the clinician put a patient at risk doing it, if it's a matter that he forgot to check the box on his privileges at the last reappointment, well, then it's a
It's an
conversation.
administrative matter
Yeah.
at that point.
Right.
So what recourse do providers have for appealing a decision that you might make?
Well, it's a miracle that this actually happens, because this was designed by legislators. And oh God, it's just monitoring education. Okay, formal investigation and corrective action. Time frame for the formal investigation, executive committee corrective action, interviews after recommended adverse action by the executive committee, board of directors action, suspension, administrative suspension, which is a different thing. For medical record, you just go on. It's not reportable and you don't have any recourse until you get them done. Nobody's really ever lost time doing it in my hospital, you know, because they suddenly have time on their hands to get it done.
Appeals procedure, I think, is the next one.
What's that?
Appeals procedure is coming.
Yeah, there is an appeals procedure.
Keep going.
Failure to maintain minimum exclusion from, so there are a variety, I mean, if you don't have a license, you're out of there. If the CMS says that you've billed incorrectly and you are excluded, exclusion is a really big deal, and you can't really practice anywhere if CMS excludes you, exclusion from government healthcare program. So you're out of there if that happens. Termination, blah, blah, blah. Hearing is an appeals procedure. So B5, let me just give you a sense of the procedure. This is all B5, representation. burdens of proof, record of the hearing, continuances, appellate review, blah, 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 joint hearing. It's exhausting. It's so, yeah, there are enormous protections built into the process for the individual. Yeah, so what can I say? So you've got to have a really tight case. Sometimes some hospitals have an arbitrator, and you present the case to the arbitrator. Some hospitals have a board of peers of other physicians, and you present your case to the other physicians. So the other things that the bylaws do are just to tidy this up is they also talk about the expectations for the physicians, the requirements for joining the medical staff categories, which is a different thing we didn't talk about, and then the whole governance structure for the hospital. And then there's a whole section of the bylaws that talks about what's necessary for a proper physical exam, for proper consultation, what to do in emergency cases. So for example, if we had a huge earthquake and all the bridges went down, in my hospital, someone living in Happy Valley who had a medical license, I can actually get them to work in my hospital if they want to volunteer, in spite of not having done 20 pages of paperwork on an emergency basis. So there are a whole variety of different circumstances that are talked about. So is there? I guess that's about it for the bylaws and the professional staff structure. So the situation for nursing staff, I think, is a little more understandable because it's an employer-employee relationship, and and you know, that's, we all experience that, know what that's like. But this independent professional staff that exists in all hospitals, and in Oregon exists in all ambulatory surgery centers also, is an unusual thing about which most people don't know very much.
I just wanted to say that I found it interesting when I came to OHSU because I work here now. I used to work at Legacy. It's a very different at OHSU because the physicians are